All right. Thank you for joining us today for this Vaccine Integrity Project live stream presentation, From Data to Decisions, the Evidence Base for 2025 Fall-Winter Immunizations. I'm Kevin Griffiths with the Vaccine Integrity Project. In just a minute, I'm going to introduce you to our distinguished group of panelists and presenters and give you a rundown of the order of presentations for today. But before I do that, I'm going to turn things over to CIDRAP Director, Dr. Michael Osterholm with the Vaccine Integrity Project, who is going to talk about what you're going to hear and why it matters. Dr. Osterholm, over to you.
Good afternoon. Thank you for joining us and for tuning in. I'm Michael Osterholm, Director of the University of Minnesota Center for Infectious Disease Research and Policy, which houses the Vaccine Integrity Project. I want to briefly outline what you're going to see and hear and why it's important. I also want to tell you a little bit about all the work that went into making today possible. As we approach the respiratory virus season with influenza, COVID, and RSV in circulation, and on the back of a flu season with nearly 270 pediatric deaths, it's more important than ever that people have clear, evidence-based information to make informed decisions about immunizations. They remain one of our most powerful tools to prevent severe illness and death, and the protection works when people know when and why to get vaccinated and trust the information that's guiding these choices. For years, there's been a transparent federal approach to approving vaccines. This is one where data are presented and discussed in open forum, and votes were then taken on recommendations. And those data for COVID, flu, and RSV were clear. Immunization was always the best protection against hospitalization and death related to those viruses, and the occurrence of serious adverse events related to vaccination were rare. Over the last few months, we've seen policy changes by federal officials based on evidence that has been shown as flawed, analytically fraught, or flat out wrong. It's vital that providers and the public continue to have vaccine information they can rely on. That's why the Vaccine Integrity Project has stepped up to tackle the question that needs answering. Are these new data that support the recent changes of vaccine policies? What you're about to hear is an analysis typically done by CDC and handed over to Advisory Committee on Immunization Practices working groups. It's a review of published data through July 2025, assembled as a meta-analysis for key populations. This presentation is the byproduct of a work by a group of 24 doctors and experts from across the country who were assembled to put together the current data on the epidemiology, vaccine effectiveness, and safety of COVID, influenza, and RSV immunizations. I want to express a huge thank you to the team for this work and to anyone who made it possible. There were many who were involved. Together, this team screened more than 17,000 abstracts and reviewed 14,006 full articles, extracting detailed data from 590 studies, including 50 randomized controlled trials. We have been working closely with key medical associations over the past few weeks, sharing evidence updates along the way. We've answered questions and examined data as they draft their immunization recommendation and guidelines for the fall and winter. Our timing is intentional. If the American public will have reliable vaccination advice from these medical societies for the fall, they require evidence-based data to support the guidelines. All of this work was guided by a research plan that was externally reviewed and pre-registered with Proserio, a global registry that promotes transparency of systematic reviews. All contributors to the Vaccine Integrity Project scientific reviews completed the Declaration of Interest form to disclose any financial and non-financial interests that could influence or be perceived as influencing their analyses. These forms are independently reviewed by University of Minnesota staff for any actual, potential, or perceived conflicts of interest according to the University of Minnesota standards and policies governing conflicts of interest. This effort was designed so that clinicians, pharmacists, and public health officials have the evidence necessary to answer questions about immunization for the three most common and dangerous respiratory viruses, so they in turn can protect the health of the people that they care for. And the public will have a one-stop shop to the latest information to inform their decisions to protect themselves and their families. Finally, I want to express my gratitude to our esteemed panelists today. They will be asking questions of our presenters, getting at the questions on the minds of clinicians and the members of the public. So now I'll turn it back over to Kevin to walk through our agenda and introduce our presenters and panelists.
Great. Thank you, Mike. I now want to introduce our presenters and panelists and briefly describe what to expect from our discussion. Joining us from the Integrity Project Science Data Review Team are infectious diseases physician and clinical associate professor at Stanford School of Medicine, Dr. Jake Scott. Caitlin Dugdale, a Massachusetts General Hospital physician and assistant professor of medicine at Harvard Medical School. Dr. Harleen Marwa, a pediatrician at Mass General Brigham for Children and instructor of pediatrics at Harvard Medical School. And Albert Einstein College of Medicine assistant professor, Dr. Michael Abers. Our presenters are going to walk us through what they found when they examined the data from COVID, influenza, and RSV studies completed since ACIP last performed comprehensive reviews, the CDC last performed comprehensive reviews. We're also joined today by a panel of public health professionals who know how to translate scientific and medical information into language people can understand and use. The panel will ask the presenters about the data they found and what it means. Panelists are Dr. Oliver Brooks, who is clinical professor of pediatrics at Charles R. Drew University of Medicine in Los Angeles. Dr. Brooks is the retired chief medical officer at Watts Healthcare Corporation in Los Angeles, past president of the National Medical Association, and past member of the ACIP. He is a board member of the National Foundation of Infectious Diseases. Dr. Caitlin Jetelina, an epidemiologist and leading scientific communicator. You probably know her from the Health Communications Enterprise, your local epidemiologist. She's also an adjunct professor at the Yale School of Public Health, sits on the medical board of the Make-A-Wish Foundation, and serves on the Lancet Commission for Trust in Health. Dr. Eric Rubin is an infectious disease physician at the Brigham Women's Hospital, a basic sciences researcher at the Harvard T.H. Chan School of Public Health, and editor-in-chief of the New England Journal of Medicine. And Dr. Mark Siegel, the senior medical analyst for Fox News. Dr. Siegel is a clinical professor of medicine and a practicing internist at NYU Langone Medical Center and the medical director of Dr. Radio on Sirius XM. For the presentations today, Dr. Scott is going to walk through how these reviews and meta-analyses for COVID, flu, and RSV immunizations were done. Dr. Dugdale will then present the top-line results for the pregnant population, followed by Dr. Marwa for pediatric populations, and Dr. Abers for the immunocompromised. Dr. Abers will also present slides on data visualization of this information, which will ultimately live on CIDRAP's site. Speaking of which, this live stream will also be posted along with the data discussed during today's conversation. With that, I'll hand the mic over to Dr. Scott.
Thank you so much. Okay. Hello, and thank you all for joining us. Today, I will be presenting the methods for our systematic review. Our objective is to transparently explain the rigorous process we used to gather and evaluate the scientific evidence on respiratory virus immunizations. The strength of these methods is fundamental to the integrity of our findings. Next slide, please. Our approach began with protocol pre-registration. Prior to reviewing any studies, we registered our complete research plan with Prospero, which is the International Prospective Register of Systematic Reviews. The protocol was also reviewed by external vaccine experts. This registration and expert review process establishes transparency and accountability to our pre-specified methods. We conducted comprehensive search databases, PubMed, Embase, and Web of Science. These databases represent the primary repositories for peer-reviewed medical literature. Our search timeframes were anchored to the most recent ACIP evidence to recommendation reviews to capture the most current and clinically relevant evidence. For influenza, we included studies published from August 2023 through July 2025, encompassing two complete flu seasons. For COVID-19 and RSV, we searched from June 2024 and August 2024 through July 2025, respectively. These timeframes refer to publication dates, not when the underlying vaccine data were collected. For RSV, our scope included both licensed vaccines and monoclonal antibodies, such as nirsevimab. While these antibodies are not vaccines, they provide pre-exposure protection for infants and are often considered by clinicians during the same patient encounters. For safety studies specifically, we included papers published within these timeframes, regardless of when the underlying data were collected. This approach ensured we captured the most recent safety analyses available in the literature. Next slide, please. To ensure the reliability of our results, we employed rigorous quality control procedures. Every article underwent dual independent screening by two researchers at both the title and abstract stage and the full text review stage. A third senior reviewer resolved any disagreements. This process minimizes individual bias and ensures consistency in study selection. Our inclusion criteria were deliberately rigorous. We required studies to evaluate US licensed or emergency authorized products, include a minimum number of 10 participants, and employ either randomized controlled trials or observational study designs with laboratory confirmed infections. We excluded preprint studies, modeling studies, and phase 1 trials for specific methodological reasons. Preprints have not undergone peer review. Animal studies do not provide human clinical data. Modeling studies do not offer real-world evidence. And phase 1 trials evaluate investigational products unlikely to be clinically available this upcoming season. This exclusion strategy focused our analysis on the highest quality peer-reviewed human data for products available in clinical practice. Next slide, please. I want to highlight the specific quality assurance measures that underpin this entire process. Our pre-registered protocol, as I mentioned, established all methods before data collection began. Data from all included studies were extracted independently by 2 reviewers using standardized electronic forms to ensure both accuracy and consistency across the data set. We conducted systematic overlap detection to identify and address duplicate populations across studies, ensuring we did not count the same patient's data more than once in our analyses. All extracted data underwent verification by our team of 11 senior researchers. Additionally, we are conducting formal risk of bias assessments for every included study using established methodological tools. Next slide, please. Our review examines 3 respiratory viruses: SARS-CoV-2, which causes COVID-19, RSV, also known as respiratory syncytial virus, and influenza, across 5 distinct population groups. These populations are pregnant individuals, children, immunocompromised individuals, older adults, and the general adult population. We stratified by population because immune responses and vaccine effectiveness can vary significantly across these groups. For each population virus combination, we examined 4 domains: epidemiology, which characterizes disease burden and severity; vaccine effectiveness, measuring protection against infection and severe outcomes; safety, monitoring safety events and concerns; and co-administration, evaluating interactions when vaccines are given concurrently. Next slide, please. For co-administration studies, we assessed both immunogenicity outcomes and safety profiles when multiple vaccines are given together, as this reflects real-world clinical practice where patients often receive multiple immunizations during the same visit. Additionally, we collected comprehensive epidemiologic data, including disease incidence, seroprevalence, hospitalization rates, critical care admission rates, medically attended visit rates, and infection fatality rates, to provide essential context for vaccine effectiveness and safety findings. Next slide, please. To ensure thoroughness and transparency, we pre-specified all outcomes we would analyze before beginning our review. For vaccine effectiveness, we examined outcomes across the full spectrum of disease severity. For severe disease outcomes, we assessed hospitalization, critical care admission, and death, as well as the composite outcome of hospitalization or death. For milder illness, we evaluated symptomatic laboratory-confirmed infection and medically attended infection. We also examined impact on daily activities, including school absenteeism and work absenteeism. These outcomes capture the range of ways vaccines can protect people from preventing the most serious consequences like death and intensive care admission, to reducing milder symptomatic illness and the broader societal impacts on work and school attendance. Next slide, please. For safety assessment, we established specific safety events of special interest for each vaccine type, focusing on conditions of particular clinical concern based on established safety profiles and regulatory guidance. For influenza vaccines, we assessed Guillain-Barré syndrome, stroke, myocardial infarction, and school absenteeism in children. For RSV vaccines and antibodies, we evaluated the same set of conditions. For COVID-19 vaccines, our safety events of special interest included myocarditis, Guillain-Barré syndrome, immune thrombocytopenic purpura, stroke, cerebral venous sinus thrombosis, and school absenteeism in children. Next slide, please. For immunizations administered during pregnancy, we examined pregnancy-specific outcomes, including preeclampsia, gestational hypertension, preterm birth before 37 weeks, placental abruption, small for gestational age, congenital anomalies, stillbirth, and miscarriage. We also collected data on all other safety events reported in studies beyond our pre-specified events of special interest for comprehensive future analysis. Next slide, please. I want to clarify the current status of our work. While our overall analysis continues, every finding presented today has completed our full methodological review process. We are presenting these completed verified results while continuing analyses for the remaining population groups. Next slide, please. Our systematic process began with 17,262 unique references identified through database searching. Following multi-stage screening, 1,406 articles proceeded to full-text review. After applying our inclusion criteria, 590 studies comprised our final evidence base, which included 62 randomized controlled trials. The accompanying heat map illustrates the distribution of studies across diseases and research domains: vaccine effectiveness, vaccine safety, epidemiology, and co-administration. Numbers represent studies with completed analysis for the 3 populations presented today. Analysis of remaining populations is ongoing. This evidence base forms the foundation for the findings we will present. Thank you for your attention, and I will now return the presentation to Kevin.
Great. Thank you, Dr. Scott. Before we move on to Dr. Dugdale with her presentation, any questions from the panelists? Okay, Caitlin.
Hey, thank you, Dr. Scott, for walking through this. I just had a quick question, mainly on the methodology. Thank you for laying it out clearly, and thanks for your effort for going through all of this. I've done these before, and it's a ridiculous amount of work, but also equally important. So with these analyses, what's always on my mind is publication bias, right? Or studies with exciting or positive results more likely to get published than studies with negative or no results, which can sometimes skew understanding. I'm curious about how your team has thought about this and ways to address it.
Yeah, great question. So, systematic reviews are always going to have, there's always the possibility of publication bias, which is where basically, signals that are not significant aren't reported or published. However, that would actually mean that we would be more likely to be presenting more of the data that's abnormal. But we will be using statistical tools and funnel plots to review for publication bias.
Thank you. Dr. Rubin.
Thanks, Dr. Scott. And let me add my congratulations. This is a huge amount of work and very important. I'm curious about the data that you don't have. What's available to organizations like ACIP that you don't have access to, and how would that information likely change your conclusions?
Well, I think that this was a very comprehensive review, and in terms of data that we don't have access to, I think a lot of that had already been covered by the ACIP in the past. But yeah, it's an important limitation for any systematic review, and we're limited to published peer-reviewed literature. We don't have access to unpublished studies or proprietary industry data or ongoing trials that haven't reported results yet. But we did take many steps to maximize our evidence capture. We searched multiple databases comprehensively. We included surveillance data and focused on recent literature. So, and we are transparent about this limitation. But, yeah.
Dr. Scott, this is Dr. Siegel. Great presentation. Very excited about this. two related questions to Dr. Rubin. Did you manage to even the playing field in terms of people that maybe have a loud voice, saying they had a side effect with the data you have versus, an overall review where you put that in the perspective of efficacy, safety? And the second point is, what about vaccines that aren't used as often, like the Novavax vaccine for COVID? Are these represented here?
Yes, great questions. So in terms of the playing field being leveled in terms of incorporating any sort of reports of potential adverse effects. Yeah, I think that we had a very broad search and we reviewed every safety event that was reported in the studies, but we focused on safety events of special interest that had been sort of predefined based on regulatory guidance and established sort of safety profiles. In terms of your second question, I'm sorry, can you repeat it for me?
The vaccines that say didn't get as much attention, like Novavax or.
Right. Yeah. So another limitation would be that, of course, we were only able to review the evidence that was, included in the literature. And, if there's more evidence on, the Pfizer and Moderna vaccines, then yes, obviously that will sort of, skew the data one way or the other. But we did include, all U.S. licensed products in our review. So if there were, a concerning signal for safety or effectiveness, we would have detected that.
Thank you. Dr. Brooks.
Yes, first of all, thank you very much, Dr. Scott. I just want to point out, first of all, what you just did. You gave transparency, including conflict of interest, accountability, quality control, which leads to the data, which leads to recommendations. And unfortunately, we need this. So I really thank you, CIDREP and VIP, for presenting this. So you went back as far as, did I hear July of 2023? How far back did your data search go?
Well, it varied. Yeah. So basically, going back in terms of publication windows, we went back to the last ACIP evidence to recommendation reviews. So it varied a bit by vaccine. Yeah. So for flu, we captured the last two complete flu seasons. For COVID, we went back to June 2024 through July 2025, and for RSV, August 2024 to 2025, July 2025. And I will add too that we started this early July. I think we had our first meeting on July 3rd. Had our protocol up within a week or so, which was pretty rapid. But because we started in July, we initially had all the data up through June. But then we wanted to make sure that it was the most up-to-date evidence possible come this presentation. So we actually extended our search through the month of July.
Thank you.
Thank you.
All right. Thank you. I'm going to move on to Dr. Dugdale with her presentation.
Thanks very much. My name is Caitlin Dugdale. I'm an infectious disease doctor at Massachusetts General Hospital in Boston. And today I'll be presenting the evidence base that we found regarding vaccines in pregnancy. Next slide. So first, a little bit of background. There's a few pregnancy-specific considerations that I think are helpful to keep in mind as we talk about vaccines in pregnancy. Some infections, including influenza, are more severe during pregnancy. Infections in pregnancy may also increase the risk of preterm birth, stillbirth, and other adverse birth outcomes. And immunizations during pregnancy can provide protection to the newborn during the first few months of life. Some of this is depicted in the figure on the right, where we have active immunization, which is when we give vaccines to mom during pregnancy. That can generate maternal antibodies, which then can pass to the baby either through the placenta while the baby is still in the womb, or through the breast milk if the baby is breastfeeding. This provides some passive protection to the baby after giving a vaccine to mom. Alternatively, there are vaccine strategies that focus on giving vaccine doses directly to baby. Baby can receive an active immunization. Usually this is not done for the first few weeks of life for some of the infections that we're talking about. Or the baby can actually receive an injection of an antibody like nirsevimab for RSV, which we'll be touching on in today's presentation. Next slide. So here we show the overall distribution of included studies regarding vaccines in pregnancy in our analysis. And what you can see here is the 3 diseases of concern up along the top axis and the 4 domains that Dr. Scott referenced along the left. So we looked at, for COVID, RSV, and flu vaccines, studies regarding vaccine effectiveness, vaccine safety, overall epidemiology of these infections in pregnancy, and also co-administration of vaccines. What this heat map depicts is that the majority of the studies that we identified from the last year or year and a half were pertaining to vaccine safety in pregnancy. Next slide. First, we'll talk about our findings related to epidemiology. We identified 1 study in the publication window that provided data on the epidemiologic trends related to the incidence of long COVID or past and COVID vaccines in pregnancy. Among 1,500 pregnant patients in the US, 1 study said that the incidence of long COVID was 7% among those vaccinated and 12% among those unvaccinated. No studies were identified that provided new data on epidemiologic trends related to RSV or influenza infection and/or vaccination in pregnancy. Next slide. Turning to vaccine effectiveness in pregnancy, which I'll refer to hereafter as VE, there were no new data on COVID or RSV VE in pregnant women in our publication window. 1 study found that influenza vaccines were 46% effective at preventing against influenza-associated emergency department and urgent care visits in pregnancy during the 2023 to 2024 flu season. Next slide. Next, we'll talk about vaccine effectiveness for vaccines given to the pregnant woman to prevent infection in baby. We found 4 studies within the publication window that examined the effectiveness of RSV vaccination in pregnancy to prevent infant hospitalization. 1 of these was a randomized controlled trial, the Matisse study, which had previously published some data, but now published more complete data from that trial. The Matisse trial found vaccine effectiveness of 70% against hospitalization within 90 days of birth for the baby, and vaccine effectiveness of 55% for hospitalization of the baby within 180 days of birth. There were also 3 test negative design studies which found that RSV vaccination was effective at preventing hospitalization among infants who were less than 6 months old, with a pooled vaccine effectiveness of 72%. Next slide. Next, we'll turn to the safety outcomes that we examined in pregnancy. And as Dr. Scott outlined, we examined multiple pregnancy-specific adverse events, as well as some events that can occur to pregnant women that are not specific to pregnancy. Next slide. First, we'll talk about the safety outcomes of special interest with COVID-19 vaccines. So in our analysis, we found data pertaining to the safety of 2 different COVID vaccines in pregnancy. First, the BNT162b2 vaccine, which I'll refer to hereafter as the Pfizer vaccine. And secondly, the mRNA-1273 vaccine, which I'll refer to as the Moderna vaccine. For each of these vaccines, we found several studies related to the outcomes of miscarriage, stillbirth, and congenital anomalies. For all of the studies that we found throughout our publication window, there were no safety concerns identified for the outcomes of miscarriage, stillbirth, or congenital anomalies with either the Pfizer or Moderna COVID-19 vaccine. Next slide. For the outcome of small for gestational age, or SGA, we found 3 studies looking at the relationship between receipt of the Pfizer vaccine in pregnancy and SGA, and one study related to the receipt of the Moderna vaccine and SGA. In all of these studies, again, there were no safety concerns identified in terms of any increased risk of small for gestational age babies. For the outcome of preterm birth, we found 3 studies pertaining to the association between receipt of the Pfizer vaccine and pregnancy and the possible outcome of preterm birth. Here we found a mixed but potentially protective effect. 2 of the 3 studies found a statistically significant benefit in terms of preventing preterm birth after mom received a vaccine in pregnancy. The 3rd study did not find any statistically significant association between receiving the Pfizer vaccine in pregnancy and having the outcome of preterm birth. On the right, for the Moderna vaccine, we found 2 studies that looked at the potential association between receiving the Moderna vaccine in pregnancy and the outcome of preterm birth. Again, here, we found that one of the 2 studies showed a potential protective effect with a statistically significant benefit in terms of preventing preterm birth if the mother received the Moderna vaccine during pregnancy. In contrast, the 2nd study didn't find a statistically significant association one way or another, so data here are somewhat mixed, but suggest a possible protective effect of these vaccines against preterm birth. Next slide. Next, we'll turn to safety outcomes with the RSV pre-fusion vaccine with a brand name Abrezvo. For Abrezvo, we found several studies pertaining to the outcomes of stillbirth, congenital anomalies, gestational hypertension or preeclampsia and eclampsia, placental abruption, and small for gestational age. Again, in all of these, we found no evidence of any statistically significant safety concern with receipt of Abrezvo during pregnancy. Next slide. For the safety outcome of preterm birth, however, the data were a bit more nuanced. So here we identified 2 studies that provided new data regarding the potential association between the RSV pre-fusion vaccine Abrezvo and the outcome of preterm birth. The first of these was data from the Matisse randomized control trial, and that was the MADI 2025 reference. This was, again, a randomized control trial that enrolled pregnant women during the COVID pandemic to either receive the RSV pre-fusion vaccine or placebo between 24 and 36 weeks of pregnancy. Data from this trial have previously been published, and final data from the trial revealed a relative risk of preterm birth of 1.2 with a confidence interval that doesn't cross 1. So what does that mean? The relative risk of 1.2 being above 1 suggests a potential association, an increased risk of preterm birth with receipt of the vaccine in pregnancy. However, there's uncertainty around this, and the confidence interval that crosses 1 suggests a non-statistically significant increase in risk if 1 is present. That said, the study investigators looked into this signal in more detail, and one of the things that they found was that women who were enrolled from low and middle income countries in this trial had an increased risk of preterm birth, whereas those who were enrolled from high income settings did not have an increased risk of preterm birth. They did many other subgroup analyses and couldn't find any other explanation for that potential safety signal. Fortunately, though, we also have a second study that was published in this window from Jinshe 2025, which shows real-world post-marketing surveillance data from after the CDC guidelines recommended that the RSV vaccine be used between 32 and 36 weeks of pregnancy, later than in the trial, and that study did not show a statistically significant increased risk of preterm birth. I see that there's some questions or some hands up. Kevin, should I turn to our panelists?
Yes, let's go. Let's do that. Okay. Let's see. Dr. Brooks.
Yeah, thank you. So the ACIP did take into consideration the preterm birth and therefore moving the recommendation to 32 to 36 weeks because the studies went down to 28 weeks. Is this new data or is this a continuation of old data regarding the low to moderate income countries with the higher rates versus first world, if you will? Or is this new data?
Thank you, Dr. Brooks. Yeah, the overall trial results were a continuation of old data, but what was new here were the subgroup analyses specific to Abrezvo in low and middle income countries. So you may remember that when the GSK RSV vaccine phase 3 trial results were published, that GSK vaccine also showed an increased risk of preterm birth. And that risk was seen more strongly in women who are enrolled in low and middle income countries. Now we have new data from Matisse showing the difference between the preterm birth rate in low and middle income countries versus high income country enrollment. So that piece of data was new, even though the overall trial data were just a continuation of prior.
Thank you.
All right, Dr. Gedolina.
Yeah, thank you for walking through this. I was kind of surprised and a little confused of the possible association words here. Was that because it, like what you said very eloquently, it doesn't cross, it crosses the one. So like it's not a P of 0.05. And so I'm wondering, is that what maybe the authors said, or is this your guys's conclusion that there may be a possible association? I'm curious the discord between those two.
Yeah, thank you, Dr. Gedolina. So know that the primary authors of that study did not report this as a potential association. We flag it as such because there was a statistically significant difference in the particular subgroup of women who were enrolled in low and middle income countries. And while that doesn't necessarily apply to the same populations of patients that we think about in the United States who may be receiving vaccine, it is something that warrants potentially future study or just more thought. As we consider how best to apply the data from the study to real world recommendations. And as Dr. Brooks already noted, the ACIP was aware of these signals in the prior study as well, and subsequently recommended the RSV vaccine later in pregnancy than was delivered in the trial.
Thank you.
Dr. Siegel.
Actually, that answer gets at some of what I was going to ask you. That's an incredible presentation. Looking back at CDC data, assuming this is accurate, COVID vaccine during pregnancy, less than 20%, RSV, 33%, flu, 47.4% in previous years, or most recently. Now, of course, we have a fear factor going on, which I've written books about. With this data, armed with this data, I don't want to ask you to speculate, but do you see a way to utilize this information clinically to help offset the fear? Because obviously it's easy to manipulate pregnant women with fear.
Absolutely. I think that's a really important question. Thank you. This is where we really, as clinicians and as researchers, we really look to the guidance of professional societies to try to steer us through. And, I know that some of the guidelines for vaccines and pregnancy are forthcoming. The scope of this review was really limited to addressing the data that exists, and we really leave any discussions about patient-facing materials or guidelines development to those professional societies.
Dr. Rubin. I think you're on mute, Dr. Rubin.
Sorry about that. Just following up a bit on Dr. Siegel's question. Is there anecdotal evidence? And I understand that you weren't collecting anecdotal evidence, you're collecting systematic data, but the women, the slightly perhaps increased risk of premature labor in women who had not received vaccine, did it seem to be associated with COVID infection?
Very, very good question. The study investigators, again, did extensive sensitivity analysis to try to disentangle this. And during the period of time that the Matisse trial was ongoing, that was, again, really during the height of the COVID pandemic, some of their subgroup analyses found temporal overlap with some of the trends in preterm birth with the COVID-19 waves in various settings in low and middle income countries where people were enrolled. But there wasn't, beyond that, any way of further disentangling the data to find a cause for that potential finding. And again, I think what's reassuring here is that we have newer data post-marketing in the US from Jin Shea and colleagues that fortunately did not find a statistically significant association with preterm birth.
All right, thank you. Dr. Dugdale, I'll turn back to you.
Okay, next slide, please. All right, moving on to influenza vaccines in pregnancy. We found 2 studies looking at the potential association between influenza vaccination and pregnancy and the outcome of miscarriage. Here, one of the 2 studies, both I should mention from the same author, but using different data sets, found a potential protective effect where women who had received the flu vaccine in pregnancy had a statistically significantly lower incidence of miscarriage than those who did not. The second study did not find any statistically significant relationship, though. And for the outcomes of stillbirth, placental abruption, and congenital anomalies, none of the studies that were identified in our search demonstrated any safety concerns of influenza vaccination in pregnancy. Next slide. Turning to the outcome of gestational hypertension or preeclampsia and eclampsia, here again we have a bit more mixed findings with flu vaccines in pregnancy. We found 3 studies that presented new data on this potential relationship. One of the 3 studies, Lee 2025, demonstrated a statistically significant benefit in terms of reducing the incidence of gestational hypertension and preeclampsia or eclampsia with vaccination. In contrast, one study, Regan 2024, found a slight statistically significant increased risk of these outcomes with flu vaccines in pregnancy. And a third study found no statistically significant association. So these findings are mixed and don't allow us to really comment on the potential directionality of the effect. But more studies, in this field would be welcome. Next slide. Turning to preterm birth for influenza, we found one study that showed a possible protective effect of flu vaccines in terms of preventing preterm birth, and one study reporting on small for gestational age that showed no safety concerns. Next slide. We also looked at safety studies of safety signals of special interest throughout other studies on outcomes that were not specific to pregnancy. So in the Matisse study, there were no reported episodes of Guillain-Barré syndrome, stroke, or myocardial infarction among pregnant women who had received the Abruzvo vaccine. Similarly, there were no increased risk of major adverse cardiovascular events with receipt of the RSV vaccine in pregnancy in that post-marketing surveillance study that I referenced. And then the risks of Guillain-Barré syndrome and stroke with immunization in pregnancy were similar with and without flu vaccines. Several studies provided data on safety outcomes not previously identified as being of special interest, so things like postpartum hemorrhage and gestational diabetes. And during our initial review, there were no major concerning safety signals around these other adverse events, again, that weren't identified as being of special interest, but these data will be analyzed in a dedicated way at a later date. Next slide. Co-administration-wise, there were no studies from our publication window that provided new data on the safety or effectiveness of COVID, RSV, or influenza immunizations for pregnant women when used in combination with other vaccines. Next slide. So in conclusion, there were no new epidemiologic data for influenza and RSV in pregnancy, but new studies supported the effectiveness of influenza vaccination to reduce medically attended infection in pregnant women and of RSV vaccination in pregnancy to reduce hospitalization among newborns. We re-identified the known potential increased risk of preterm birth with RSV prefusion vaccines, particularly if given early in pregnancy. And for all other pregnancy outcomes examined, the risk of adverse outcomes with COVID, RSV, and influenza immunization in pregnancy was similar to or less than not receiving immunization in pregnancy. And here I'll also build off of the question that Dr. Jedalina asked earlier about publication bias. When we're looking for the presence of an adverse outcome, that we would expect for publication bias to actually result in fewer studies published that show no association with the outcome. So if anything, the fact that we are finding studies that show no association with the outcome is even more reassuring. And with that, I'll go ahead and hand it back over to Kevin.
Great, thank you. Any additional questions, Dr. Jedalina?
Thank you for the presentation. I'm kind of surprised we don't have effectiveness data on the COVID-19 vaccine in pregnancy. So I assume, it makes me feel very good that they're continuing to look at the safety, but are you making the assumption then that the effectiveness hasn't changed? It's still as effective as it was in 2023? How are you guys thinking about that?
Yeah, thanks for that question. We are limited throughout the publication window that we examined. Just to reiterate, we obviously did not review the entire body of COVID efficacy and pregnancy data. We only looked at studies that were published from the last year or so, and there were no new effectiveness data that we found in our search. That said, the data, we can lean on the data that were previously reviewed by ACIP and other organizations that supported the prior recommendations for COVID-19 vaccines and pregnancy. We just can say there were no new published data available to us at this time.
Great. Dr. Brooks.
Yes, thank you. So do you have data that shows that the vaccine effectiveness for influenza in pregnant women tends to mirror the broader population, i.e. if it's higher one year versus lower the next year, we would tend to see the same pattern in pregnant people?
Yeah, great question. I think, one would reasonably assume that, but we can't say that we have any data on that as of yet. We are currently analyzing the data on influenza vaccine effectiveness in general adult populations, and we'll be able to share at a later date how those data found from the last year and a half compared to the pregnant populations that we have examined already.
Thank you.
Dr. Siegel.
Is there anybody this is a related question to previous, is there anybody accumulating data on hospitalization of COVID patients who are pregnant, either statewide or federal at this point?
Yeah, thanks, Dr. Siegel. If there are, I'm not privy to those data. It was outside of the scope of our review, which of course is the published data. But beyond that, I can't comment as to whether the professional societies who are crafting these guidelines, for example, have access to more of the real-time data that were previously, being collected and shared with groups like ACIP.
Okay. I do think that I just want to point out that it's worth reiterating, because I think Dr. Jedeline's question is a really important one, that essentially that the work here that our science review team did really stands on the shoulders of the huge body of evidence that existed prior to the work that they've done to review the literature that has been that has come out more recently and hasn't yet been subject to a review by CDC. So we're really trying to make sure there's no gap in that the body of evidence. So with that, I want to go ahead and hand it off to Dr. Marwa.
Great. Thank you so much, and good afternoon, everybody. My name is Dr. Harleen Marwa. I am a pediatrician with Mass General Brigham and an instructor of pediatrics at the Harvard Medical School, and I'm going to be walking us through the pediatric population analysis. Next slide, please. So to begin, it's important to note that children have specific characteristics with regards to both their physiology and development that make them particularly vulnerable to the respiratory illnesses that we're covering today. As Dr. Dugdale already discussed, immunizations given during pregnancy may protect infants during the first months of life from maternal antibodies that have crossed the placenta. Infants under 6 months are at high risk for severe illness from many infections as their immune system is maturing. Children more generally are also at increased risk for serious illnesses from many infections due to factors like a developing immune system, narrower or smaller airways, lower pulmonary or lung reserve, weaker respiratory muscles, and more. And further, illness in children can lead to things like missed school days for them or missed work days for their caregivers, having broader consequences on development and family stability. Next slide, please. Here we show the distribution of outcomes included in the pediatric population analysis. Of the outcomes identified, there were 18 focused on COVID, 23 on RSV, and 28 on influenza. Looking at this by domain, there were 40 on vaccine effectiveness, or VE, 13 on vaccine safety, 13 on epidemiology, and 3 on co-administration. And just as a reminder, the studies on neonatal outcomes like prematurity, gestational size, and congenital defects were included in the pregnancy analysis just shared by Dr. Dugdale. Next slide, please. So starting with epidemiology, as I mentioned, our search identified 13 studies that covered U.S. epidemiologic trends since January of 2024 with regards to the pediatric population and the viruses of focus. Age ranges for these studies included birth through 18 years. With regards to COVID, our search identified 3 studies, with 2 of the 3 studies including early childhood populations, defined here as under 5 years. These studies pooled from both national and regional databases. Outcomes reported included maternal vaccination status, hospitalization rates, hospitalization outcomes, and prevalence and incidence of co-detection. With regards to RSV, our search identified 4 studies, with 2 of the 4 studies including early childhood populations. These studies included national, regional, and single-site settings. Outcomes reported included viral gene sequencing patterns, RSV-associated hospitalization rates, hospitalization outcomes, and prevalence and incidence of co-detection. And finally, with regards to influenza, our search identified 6 studies, with 2 studies including early childhood populations. These studies included national and regional settings, and outcomes reported included trends in vaccination rates, prevalence and incidence of co-detection, outpatient visits and hospitalizations, hospitalization outcomes, and trends in influenza-associated encephalopathy. Next slide, please. I just want to spend a moment on that last outcome of influenza-associated encephalopathy, or IAE, as this was an area of interest during the most recent influenza season. 2 studies, Fazal 2025 and Silverman 2025, looked further at this outcome. Fazal 2025 looked at trends in proportions of cases with influenza-associated encephalopathy or encephalitis among influenza-associated pediatric deaths from 2010 to 2011 through the 2024 to 2025 influenza seasons. The study found that among the 1,840 pediatric influenza-associated deaths, 9% had IAE. And this ranged from 14% in the 2011 to 2012 season to 0% in the 2020 to 21 season, and preliminary data for the most recent season through February 8th of this year indicate that 9 of 68, or 13% of patients had IAE. And of the patients identified with IAE, about 80% had not received a dose of that season's influenza vaccine more than 2 weeks before illness onset. Silverman 2025 looked at children diagnosed with acute necrotizing encephalitis, a severe form of IAE, with longitudinal follow-up. Cases in this one were identified from October of 2023 to May of 2025. And investigators found that 32 of the 38 cases of ANE with available vaccination history had not received age-appropriate seasonal influenza vaccination. They further found that of the 11 patients in their studies who died of ANE from complications, 10 had not received age-appropriate seasonal influenza vaccination. Next slide, please. Transitioning into vaccine effectiveness, our search identified a number of studies that reviewed vaccine effectiveness trends with regards to the pediatric population. As you can see in these tables, data largely focused on RSV hospitalization outcomes with nirsevimab. Second to hospitalization was data on medically attended and symptomatic infections. Next slide, please. Tardoff 2024 examined vaccine effectiveness of the COVID BNT162b2 or Pfizer vaccine on both emergency department visits or hospitalization. This study found a protective effect in the age range studied, which was 5 to 17 years, both by overall analysis and by subgroups 5 to 11 years and 12 to 17 years. Next slide, please. There were 13 studies identified in our search that looked at the effectiveness of nirsevimab for RSV hospitalizations in children under 24 months of age. The exact age inclusion of these studies varies and is combined on these slides. Next slide, please. Across these 13 studies, effectiveness data ranged from 64% to 93%, demonstrating overall protective effect of nirsevimab on RSV hospitalization for patients less than 24 months of age. Next slide, please. There were 6 studies identified in our search that looked at the effectiveness of nirsevimab for RSV intensive care unit or ICU admissions in children under 24 months of age. Again, exact age inclusion of these studies varied and is combined on these slides. Across these studies, effectiveness data ranged from 51% to 91%, demonstrating an overall protective effect of nirsevimab on RSV ICU admission in children under 24 months of age. Next slide, please. There were 5 studies identified in our search that looked at the effectiveness of nirsevimab for medically attended infections, again in children under 24 months of age. Across these studies, effectiveness data ranged from 17% to 89%, with 4 of the 5 studies showing a greater than 50% protective effect, demonstrating overall protective effect of nirsevimab on medically attended RSV for patients younger than 24 months. Next slide, please. Transitioning to influenza now. There were 7 studies identified in our search that looked at the effectiveness of the influenza vaccination for hospitalization or ICU admission across children under 18 years of age. These studies showed an overall protective effect ranging from 46 to 78%. Next slide, please. There were 15 studies identified in our search that looked at effectiveness of influenza vaccination for medically attended infections across children under 18 years of age. Exact age inclusion of these studies varied, and so is combined on this slides. Next slide, please. And across the 15 studies, vaccine effectiveness ranged from 32 to 92%, demonstrating an overall protective effect of the influenza vaccination on medically attended influenza in children under 18 years of age. Next slide, please. So now we'll transition to the safety outcomes of special interest. Our search identified a number of studies looking at safety events of special interest, as we discussed earlier. And as you can see from this table, these outcomes were focused on the influence of the COVID vaccination on both myocarditis and Guillain-Barré syndrome, referred to as GBS on the slide. Again, the studies that looked at neonatal outcomes were previously covered in the pregnancy population analysis. And I just wanted to note there was no study identified in our search that covered immunization and school absenteeism. Next slide, please. So of the studies looking at myocarditis, 4 included the Pfizer vaccine and 4 included the Moderna vaccine. And one of these, SO 2024, included both. While these studies varied in design, they were consistent with what is already known about the risk of myocarditis, with incidence being highest after the second dose of the primary series. New data are in line with emerging adult literature that indicate risk decreases with subsequent booster doses, pointing to time between vaccinations. Next slide, please. There were 2 studies identified in our search looking at COVID vaccination and Guillain-Barré syndrome. Of these, there was no new safety signals identified in patients ranging from 6 months to 11 years. Next slide, please. And now we'll transition to the co-administration findings. There were 2 studies identified in our search that examined co-administration outcomes with COVID vaccination and influenza vaccination. Of these, no serious adverse events were reported. Next slide, please. So in conclusion, there was a moderate volume of new data regarding the epidemiology of COVID, RSV, and influenza among children of all ages, with new data suggesting pediatric influenza-associated encephalopathy cases have varied by year, and the rates are higher among unvaccinated groups. The new data on RSV immunization showed protective effect of nirsevimab on RSV hospitalization, RSV ICU admission, and medically attended RSV for patients less than 24 months of age. There were no new safety signals identified for the COVID booster and myocarditis, and the new data on COVID and influenza vaccine co-administration showed no serious adverse events. Thank you for your time and attention, and I'll turn it back over to Kevin.
Great, thank you. Dr. Siegel, I think I saw you first.
That was an incredible presentation. You need to get an immediate promotion. And it actually answered my question from before, which is, of course, infants are extremely well protected if their mother gets a vaccination. And to Kevin's point previously, we have plenty of data that the COVID vaccines lead to fewer hospitalizations from COVID if you get them during pregnancy. But I thought that was extremely comprehensive and very important about nirsevimab. And congratulations on that presentation.
Oh, thank you.
Dr. Gedalina. Nope, I think you're on mute.
Gosh dang it. Thank you. Fantastic presentation. The RSV protection always blows me away, especially with these real world studies. I have a question about the COVID vaccine, and I was trying to look real closely with the age ranges, but often older adults are cited as the highest risk for severe outcomes of COVID, but more and more concern has been raised about the risk of infants, particularly under 24 months. We're right now in a COVID wave, and they have the highest rate of ED visits compared to any other age group right now. What did the data demonstrate about the risks for COVID in the population and the protection of vaccination for this age group after pregnancy in particular?
Yeah, thank you so much for raising that important point. I think as I mentioned at the top of the presentation, and as you just reaffirmed, young children are at high risk of these respiratory infections for a variety of reasons. In terms of what this newest evidence and what we included in our search and that we're able to identify showed, there wasn't necessarily new evidence here pointing to those things. However, it stands on the shoulders, as Kevin mentioned earlier, of an existing body of evidence that has reaffirmed the concerns that you mentioned. I would recommend, I would refer you to the American Academy of Pediatrics, as they have been, grappling with this data for a long time and released additional recommendations specifically with regards to your question this morning.
Dr. Malwa, do you want to just mention what that recommendation was, just so for folks watching?
Yeah, absolutely. So this morning, the AAP released updated vaccine recommendations, and specifically with regards to the COVID vaccination, they recommended the COVID vaccination for children 6 to 23 months. So identifying that high-risk population that you just mentioned, Dr. Gedalina, and for those who live with people who are at high risk for illness. In their recommendations, they emphasize that kids who are immunocompromised should also be vaccinated, and further endorsed access to vaccines for all children, but really emphasize the need for those at the highest risk.
Thank you. Dr. Brooks.
Right. And also, I believe they endorse, I guess you stated, indirectly shared clinical decision-making for children 2 years and up.
Yes, thank you.
And this is different from the current recommendations. So I think that's significant. So again, excellent presentation. A couple of questions. First, clesrovimab was approved at the most current ACIP meeting. You had no data on that you presented. Shall we extrapolate that clesrovimab will mirror nirsevimab in terms of vaccine effectiveness, that you had 64 to 93% or somewhere in that range?
Yeah, I think it's a really good question. Like we mentioned earlier, we're really limited by the scope of this search, and so because the data that we reviewed was on nirsevimab, it's hard for me to make that conclusion. But certainly, I think it points to an opportunity for similar studies to be conducted.
Okay, and then regarding the myocarditis, so if you look at children, I think if you do the antibodies, 90+% of them will test positive, either from vaccination or natural infection. So the myocarditis was an issue with teenagers, mid-age, young adults. Can we infer that we look at that natural infection as quote unquote a dose? So as they get older and get exposed and maybe had one dose of vaccine, that we could look at them as having maybe two, And then therefore their risk of myocarditis is lower. As you stated, it gets lower per the number of doses, increasing number of doses you receive.
Yeah, you bring up a really interesting question, and I should probably clarify what I presented earlier. It's actually the highest risk was seen after dose 2. So I think that that mirrors what you're saying of is after additional exposure. But looking at emerging literature on the adult side, and looking at the literature that we presented today, in terms of booster doses, there seems to be lower risk associated with booster doses, and some of the adult literature points to the time interval between vaccines. As that progresses, the risk continues to go down.
And very quickly, the risk of myocarditis and the outcome from COVID
Yes.
in an unvaccinated individual wasn't discussed and wasn't necessarily relevant, but I think it's important for that to be noted.
Yes, thank you. Yep, what we were seeing was similar to background incidence rates.
Okay, great, thank you. Dr. Rubin?
Dr. Marwa, thanks. That was fantastic. Another fantastic presentation today. It's a methodologic question. Looking at some of the outcomes, you had medically attended visits with the nirsevimab data. There was a very broad range of outcomes. Most 4 of the studies showed very, very strong protection. One of them showed 17% and wasn't statistically significant. How do you think about the quality of studies? You're certainly you're choosing studies with good methodology, but when there are outliers like that.
Yeah, you bring up a really good point, and something I thought a lot about too when I was looking across those 5 studies. The thing I'll note about that particular study was the 17% number, I believe, came from medically attended infections at the 180-day mark, but at the 30-day mark was at around 69-70%. And so also kind of looking at the duration of vaccine effectiveness. I think the other thing that I'll point to there is that 4 of the 5 studies did show a protective effect greater than 50%, which gives us more confidence to say that the vaccine was effective for that outcome. I think more broadly, your question about looking at the quality of these studies, I think certainly study design and quality varied across the studies, and our team is planning to do further analyses to both talk about the heterogeneity across the studies and also risk of bias.
Okay, Dr. Siegel.
Actually, Oliver asked pretty much this question, but it's so important and it's received so much attention. He already answered it. I want to see if I could slice it a different way, which is there's so much media attention on myocarditis in teens. One of the things that I had kind of gotten in my brain by 2022, because of that study in Circulation and other studies that showed that vaccination actually decreased your overall risk of myocarditis from COVID or related to COVID. And I understand that the slice you did of this didn't increase information or depth. There's not new data on this, but I still wonder if you could put all this together for me. The risk of myocarditis associated with COVID, age groups, I understood your focus on how long after vaccination and how many boosters you've had versus the risk from COVID itself.
Yeah, thank you so much. I think I agree. This is something that has been in the news. Parents may be concerned, and is certainly something clinicians are paying attention to as well. I think, like we said earlier, the work that we presented today stands on the shoulders of a huge body of evidence that's been out there regarding this topic. People can certainly refer to specialty societies like the American Heart Association or the American Academy of Pediatrics for additional consensus statements and recommendations. I think in our analysis of this most recent literature, data remained consistent with prior and emerging adult literature that demonstrated a baseline incidence of myocarditis following COVID-19 vaccination, higher incidence occurring after dose 2 of the primary series, and lower incidence with subsequent booster doses. And I will note that of these cases, most appear to be mild cases of myocarditis. It has been previously studied that the risk of myocarditis after the mRNA COVID vaccination is lower than the risk after the COVID-19 infection. But that was not included in the scope of today's analysis.
And just to add, in males, because I don't believe you said that. This was not found in females, to my recollection.
Yes, thank you. In
All right.
males, adolescent males.
Okay. All right. Thank you. All right. Let's move on to Dr. Abers.
Great, thank you, Kevin. Hi, everyone. My name is Michael Abers, and I am an infectious disease doctor at Albert Einstein College of Medicine, and I will be talking about our findings in the immunocompromised patient population. Next slide, please. So before jumping into our findings, I think it's important we define these terms that I'll be using about what it means to be immunocompromised. So if you really think about what the goal of the immune system is, it's really to protect us against pathogens in the environment that we could be exposed to. And vaccines work primarily by training the immune system to more rapidly recognize or eliminate these pathogens. So when you think about someone who has an impairment in their immune response, for certain infections, they might be at increased risk of acquiring the infection or of developing severe complications of an infection. And the same mechanisms that allow someone to be protected against infection sometimes overlap with the mechanisms that allow vaccines to be protective. As a result, vaccination in this patient population can be a challenge because patients are sometimes less responsive to vaccination. Next slide, please. So in the literature, a variety of different conditions have been associated with immunocompromise, and the studies that we looked at used different definitions of what it means to be immunocompromised. But in general, most studies used these big 5 categories here. Starting at the very top, organ transplantation, either solid organ transplant, such as transplants of kidneys, liver, lung, or heart, or bone marrow transplantation, which is an intervention often used for patients with leukemia or lymphoma. Cancer can also lead to a state of immunocompromise, either from the primary tumor itself, like in leukemia and lymphoma, or from chemotherapy, which can damage the immune system and the ability to fight infection. Other conditions similar to cancer, autoimmune conditions and immune system disorders, while not similar processes to cancers, they are often treated with medications that can impair the immune system and predispose individuals to infections and severe infections. And then other conditions like advanced HIV infection or inherited immunodeficiencies can strongly predispose to severe infections. So that's really the type of patient population we're talking about here. Next slide, please. Looking at our overall findings by research domain and by virus, we see that COVID has 7 studies that we were able to identify in the realm of vaccine effectiveness, 5 for vaccine safety, and 1 study reported on epidemiology. For RSV, we found 1 study that reported on vaccine effectiveness and 2 that reported on safety. And for influenza, we came across 5 studies that report on vaccine effectiveness. And I'll be approaching these virus by virus and going through the results. So we'll start with COVID. Next slide, please. So for COVID, looking at vaccine effectiveness, we identified 4 studies that include patients who were all above the age of 18. So these are adults who are immunocompromised, and the studies differed in their methodology, but they evaluated how effective is the COVID vaccine in protecting patients who are immunocompromised. While the plot in this results column here is slightly misleading because the studies themselves weren't necessarily comparing healthy individuals to immunocompromised, we show the data here together just to get a general sense that vaccines were similarly effective in the overall population of immunocompromised patients as they were in the general healthy population. Although in some of these studies, digging into the details a little further, there were certain patient populations who responded less robustly to the vaccine. I think overall, what the takeaway message here is for immunocompromised patients, even if vaccination is slightly less effective than in their immunocompetent peers, overall vaccination is certainly protective against severe outcomes of COVID. Next slide, please. Looking at RSV, this is an area that there hadn't been too much known prior to our literature review. And we found one study that looked at patients who are age 60 or greater who are immunocompromised and analyzed the safety and effectiveness of RSV vaccination. Interestingly, what this study found is that if you take the immunocompromised population as a whole, vaccination was protective against RSV infection. If you look specifically at certain patient populations, like solid organ transplant recipients, vaccination was very effective against preventing infection. And one population in particular where those results didn't seem to be as compelling for was this population of bone marrow transplant recipients, where the vaccine effectiveness was substantially lower than in other patient populations. It's important to note that the vaccine effectiveness for bone marrow transplant recipients still suggests that vaccination is somewhat protective, but it certainly isn't as robust protection as in other patient populations. Overall, these data were very compelling to suggest that vaccination against RSV successfully protects immunocompromised patients against RSV infection. Next slide, please. Going into the safety data for RSV, prior studies, and this was sort of known before we conducted this literature search, that in the general healthy population, there was an increased risk of Guillain-Barré syndrome for Abrysvo and for Arexvy. This study was one of the first here, shown here, to report on those adverse events in immunocompromised patients specifically. And what the study found overall is that for Abrysvo, but not for Arexvy, there was a small but statistically significant signal for an increased risk of Guillain-Barré syndrome in that patient population. Now, it's really important to mention here that the overall risk, and what I mean by that is how common is it to develop Guillain-Barré syndrome if you look at an overall patient population of immunocompromised, is extremely rare. So we're talking about a complication that's on the order of less than one case per 30,000 individuals vaccinated. So while there is a signal here, it is a small overall risk. And I'll just mention that the other study that we identified included a very small number of patients, really an insufficient number of cases overall to really contribute to our understanding of this overall risk. Next slide, please. Finally, turning to influenza, we found 4 studies that evaluated vaccine effectiveness. Again, these studies were all in adults who are immunocompromised, age greater than or equal to 18 years. And what these studies found is that if you look at the overall population of immunocompromised individuals, vaccination was protective against influenza, while less effective than for the immunocompetent patients. It was still effective at preventing influenza. Looking specifically at solid organ transplant recipients, vaccination in one study was partially, or I guess I'll say minimally protective, but that was a small study, and the estimate that we were able to derive would spanned a very wide confidence interval. So a small study, really an unclear what to take away from that study other than more data are needed. Finally, there was one study done, a randomized controlled trial in solid organ transplant recipients, evaluating whether high-dose vaccination or standard dose vaccination or M59 adjuvant vaccination is more immunogenic. And that just is a term that really applies to the measure of an immune response to vaccination, not necessarily a clinical outcome. That study really was too small and not really designed properly to evaluate whether these vaccines are more or less effective. So that's still an unknown in the world of vaccination in solid organ transplant recipients, whether these vaccines will be more or less effective than one another. Overall, though, vaccination against flu in immunocompromised hosts did seem to prevent infection, and that really is the big take home for the overall population of immunocompromised patients. Next slide, please. So the conclusions overall are that for all three vaccines, if you look at the overall immunocompromised population, vaccination is effective. While it might not be quite as effective as in immunocompetent individuals, it is still effective in preventing infection and often severe outcomes of these infections. And while the safety signal that was previously observed in healthy individuals for Breezvo and the risk of Guillain-Barré syndrome also seems to apply to immunocompromised individuals, the overall risk is very small. Next slide, please. Thanks.
Okay. All right. Questions? Dr. Brooks.
Thank you. I think it's important, first of all, that we look at this population. I believe that we haven't overlooked them in ACIP, but I think in general, I believe they're approximately, I've heard 3% of the population, but a significant aspect of the population because of their relative vulnerability. So a couple things. First of all, with the COVID vaccine, I guess I would have expected a slightly lower response from the immunocompromised versus immunocompetent. So I was just, it was one of the four, I believe, that showed a lower response, but we can see a relative response in their immune systems versus hospitalization.
So that's a great question, Dr. Brooks. So if you look overall at the studies, not necessarily limited to our time period, but the prior literature, I will just mention that was what you mentioned was found is that if you look overall, there tends to be a decrease in effectiveness. Now, while it wasn't something that we looked at here, I will just mention that over time, there has been a change in practice about how many vaccine doses individuals are receiving. And one study actually did look at whether patients who were immunocompromised had received a greater number of vaccine doses than immunocompetent, and they certainly had. So it's very difficult to compare these populations because they're managed differently. But from the data that we were looking at, what we found is that if you just take away, what practitioners are doing in practice, whether that practice is different, it is leading overall to vaccine efficacy. It's leading to protection.
And, that means that they are focusing on that population more, which is what needs to happen. I love to hear that. The other thing is that for the increase, the signal with GBS and RSV, about 1 in 30,000 is there a background? What percent who would get GBS unvaccinated, just the general, I guess, immunocompromised population? That I don't know if that data is even available.
That's a great question about what the background rate is in immunocompromised population. I imagine it would be different for different types of immunocompromised states, but I'll just say that it was beyond the scope of that study. That study was, the design of that study wouldn't address that question. So it's unknown from the data that we have.
Thank you.
Dr. Rubin.
Thanks, Dr. Abrams. Great presentation. And thanks particularly for pointing out the difference between relative risk and absolute risk, because I think that was a very important point. As an infectious disease practitioner, you see these very heterogeneous patients, as you described at the beginning. They have T cell defects or B cell defects, or they're neutropenic, or they have some mixture of those. And the data you're presenting, just aren't that granular. Are there data that should be collected that help apply these concerns to a specific patient out there, rather than this sort of broad basket of patients who are quite different from one another?
Yeah, thank you, Dr. Rubin. That's a fantastic question, and it really is at the heart of really all clinical research studies on the immunocompromised patient population. They're often lumped together for practical purposes in research, but clinically, these are very different groups of individuals with very different problems. While there's been a movement, I think slowly over time, for people to get more granular in the patient populations they're looking at, outside of solid organ transplantation, that really, and a few autoimmune conditions, that really hasn't been done systematically. I think the data that really need to be collected are much more granular about what dosage of a medication patients are on, what the temporal association is between that medication and vaccination, and what the patients were ultimately vaccinated with. Now, we don't have access to those data from the literature, but certainly those data would provide much more granularity about which populations are more or less protected against infection after vaccination.
Okay, thank you. Dr. Siegel.
Hard to follow the editor-in-chief of New England Journal of Medicine, and the anticipating questions that I might ask, but here are two different ones. Semi-immunocompromised populations like diabetics, can they be studied specifically? And second question, unrelated, is I remember at least early in the pandemic, we used to check antibody titers to see whether immunocompromised patients were responding. Is there data on that you looked at? Those two questions.
Those are both fantastic questions. I'll address them one at a time. The first question actually I'll start with the second question because I can more directly answer that one just by saying that these studies did not look at prior immunologic markers of whether patients had responded, quote unquote, to vaccination or infection. We're limited again by the data we have, and the data we have don't necessarily address that question, but it is nonetheless a very important one. And can you tell me again what the first question was?
The first question is about the issue of what semi-immunocompromised might be. Obviously, we've discussed the pregnant population, incredible presentation, but what about something like a diabetic or some specific group that you might consider semi-immunocompromised?
Right, that is a great question. If you look at certain individuals with non-severely immunocompromised states, like diabetes is one, we could go back now to our analyses and look at that. It's not something we did as part of this round of investigations on the immunocompromised host. We have collected data on adults as well, while not presented today, and we certainly could go back and look at that. I think to your point, I think it will be very important to go back and look at conditions like the very elderly and patients who are diabetic and other vulnerable populations and evaluate vaccine efficacy in those groups as well.
Dr. Giardolina. Oh, I think you're muted there.
Keep doing that. I just had a follow-up to Dr. Brooks' question. I was also equally surprised about the point estimates with healthy versus immunocompromised. I think it's fascinating the answer you gave about the background behavior around them getting more vaccine. I think that's fascinating. I also had a question. Did that study look at waning too? So I get that the point estimates are similar. Like, what about the time effect as well?
So thank you. That is a really, really important question. It's something that I think in all of the studies we look at, in really digging into the granularity of the studies, we're often reporting single values, but really many of these estimates are often more dynamic. You can evaluate vaccine efficacy at various points in time. And in one study actually that we included, one of the studies on COVID, they did look at the efficacy of vaccination as a function of time since vaccination. And essentially in immunocompetent adults, there was a waning effectiveness of the vaccine. And that seemed to follow a similar time pattern or similar magnitude of decrease over time in the immunocompromised host. It wasn't directly compared, but in both patient populations, it did seem to decrease over time.
That is such great news for immunocompromised patients. Thank you so much.
Right, Dr. Brooks.
And that was exactly the question I had, Caitlin. No one has presented immunogenicity data, and I'm glad, because it doesn't matter. What matters is hospitalization. Well, I can't say it doesn't matter, but hospitalization, illness, death, right? And so I wondered whether there was waning of immunogenicity or antibody levels over time in immunocompromised versus immunocompetent. But it's the hospitalization, illness, and death that matters. So I will just end there. I don't need to belabor that. If there's any comment you want to make on that, but Caitlin asked exactly what I was concerned about. And I understand what you're saying. It's a population. It's 80%, 70%, 60%, let's say over time. So you present that, let's say 70, but that's how I see it.
Thank you.
Okay. Dr. Abers, you want to just walk through your couple of slides on the visualization that will ultimately live on the Vaccine Integrity Project site?
Sure. So now I'll talk about a visualization tool that we have developed to facilitate the public's involvement really in our data and to increase data transparency. Next slide, please. So this is a really complex data set that we've assembled here. We have 3 viruses, 17 vaccine products. We looked at 5 pre-specified patient populations in 4 study domains, each with a wide range of outcomes. So you can slice this data set in a wide variety of ways, and it's impossible for us in a single presentation or even multiple presentations to address every possible question that could come up. So to sort of provide power to the people and to facilitate future research efforts and questions that come up by the general public, we created a data visualization tool where you can really see in real time our results and explore them in more detail. Next slide, please. So this tool will ultimately be publicly available, but I'll just demo or walk you through a few features of this visualization tool that we have developed. So here we're showing a heat map similar to the one we showed earlier, looking at the number of studies in each of the various viruses and each of the various study domains that we looked at. Next slide, please. So now we'll walk through the vaccine effectiveness tab. And if you just want to look at studies on vaccine effectiveness, you can then get a plot of all of the studies for various viruses and the various outcomes they looked at. Next slide, please. You can go in and then select individual patient populations that you're interested in, viruses that you're interested in. Next slide, please. And for this example, let's say you're interested in just looking at adults and elderly. So what you're looking at now in that figure right there is the overall results just as it relates to adults and elderly, with all the other populations excluded. Next slide, please. You can then go in and say you want to look at a different outcome. So next slide, please. You can hit the x-axis variable, for instance, and you're given a variety of options. So initially, in this plot shown right now, we're looking at each virus along the x-axis, but we could say, let's look at each vaccine. Next slide, please. And then what we can see is the number of studies per vaccine, rather than looking at them per virus. Next slide, please. Moving on to vaccine safety, we get a similar plot looking here at the various adverse events that we were interested in along the y-axis, and along the x-axis, we're looking at the various vaccines. Next slide, please. We can then go in and, just as we did before, select certain variables that we're interested in looking at on the axes. So now we're looking not at each vaccine, but by each virus. Next slide, please. And then we can go back to select a certain virus. Let's say we're only interested in one of these 3. Next slide, please. We can select just COVID. Next slide, please. And then we can change the variable that's along the x-axis to say we're interested in looking at all the COVID vaccines for each of the various types of investigation or each of the types of study design that we looked at. For instance, a cross-sectional study or a randomized controlled trial or an observational study. Next slide, please. So that is just a preview of this tool that we're working on. It will have a much more robust set of visualizations and more interactive components that will allow you to delve into detail and look at our findings, which I think will be helpful for professional societies in looking at what data are available, and the general public just to sort of have full transparency and full access to the analyses that we performed.
Okay. Dr. Jetelina.
Michael, that tool is incredible. I wish we had that throughout the entire pandemic. I'll be honest. Like that is incredible. It's a way to empower the public and physicians out there. There was a ton of data presented. I'm assuming the data presentation is done. Is that right? Or is there more?
There's more data that's being collected, and so
Okay.
there ultimately will be collected in one compendium, and the idea being that we'll publish all of the data.
Yeah, I mean, there was a ton of data and results presented today. So I just kind of wanted to summarize it and see if this is the right summary to take away from this. Am I correct in understanding that from the distillation of all of this evidence, it supports recommendations for widespread access across populations for all three vaccines, right? Not just including those who are immunocompromised. Am I coming to the right conclusion of that?
Do you mean the data visualization tool?
Just all of the data that has been presented today.
So the data that we presented today, really, the goal of it really was to assemble the information, synthesize it so that we can then pass it off to the individual professional societies that will make recommendations. So I think, really thinking about what our role here is and really what we focused on was just providing evidence for ultimately for recommendations to be given by professional societies.
Yeah. I think your point is an important one, Caitlin, which is that they really look to see in the newest data that was available, published data that was available, was there a change that would indicate that there needed to be less access or some type of curve on access? And so, looking through 17,000 different abstracts, they were not able to find anything that suggested that there should be limitations on access or anything that would, for instance, change the recommendations that we've seen recently for the most vulnerable populations. And I think Mike will talk a little bit about that in his follow-up. Okay, Dr. Siegel.
I don't have any really more questions, but I also wanted to say an incredible presentation today, and and the conclusion. And I share Dr. Gedolina's amazement with that tool. And Dr. Brooks's point, it's clinical outcome that matters the most. And the last tool is certainly a way to slice across populations and help to figure that out. We already know it. I mean, look, when the Pfizer vaccine came out, the entire country of Israel was given it pretty much, and then they monitored clinical outcome. We all remember that. But the point is to assemble data in this way and assess clinical outcome, and it's just extraordinary, very, very powerful. Thank you.
And I should clarify, it's not as more data is being collected, it's that it's being analyzed and ultimately would be abstracted.
I understood. It's
my mistake.
Ongoing.
Yeah. Okay. Dr. Brooks?
Right. So I'm kind of with Caitlin, looking at the summary of everything that was presented today. First of all, the tool is amazing. It's really good to have something like that. And we appreciate the concept that was made public and made whole. Access. So I have two or three questions or comments. First of all, we're talking about access, and we're not the ones that created, we're providing the information, and I don't know if this question is not necessarily for Dr. Abers, but just in general, will there be access? We present the information, but will this be accessible to the general population, which means the insurance companies, VFC, commercial, whoever provides vaccines to physicians and pharmacies and others that give vaccines, because ultimately a vaccine doesn't work until it's injected into someone. Do we know that based on the information, the vaccines that we saw today, as Caitlin would try to say, but she didn't finish, are safe and effective, and there's nothing that we've seen that has shown anything different today, it's been affirmed. Will there be access to the general population that says, I want my 8-year-old to get his COVID vaccine?
Yeah, I can take a crack at that. Yeah, I mean, I think that basically the summary of all of our results is that there's very strong evidence that vaccines work across all three of these populations that we discussed today, with generally very favorable safety profiles. And I think that not only is access, critical, but access to the actual vaccines. But I would also emphasize that access to accurate evidence-based information is obviously very critical as well. And so I think that that was, our main goal here. And I think that, we'll do everything we can to make sure that this information is accessible and promote access to the actual vaccines as well.
This is Mike. Let me just add in my concluding comments. I was going to address this, but I think since it's already been raised, let me just be clear. We've looked at this very carefully, and there simply is no scientific evidence to support the change that HHS made to the COVID recommendations for pregnant women or for children most at risk for high-risk transmission or severe disease. I think we're going to see leadership come forward, however, from our medical societies. I think the American Academy of Pediatrics today and their statements, which I thought were, very consistent with the data. We've been working with them to share the data. We applaud what they did. And I think we're going to find ourselves in a very difficult time where the body of science will be supporting the fact that what we've just concluded here is in fact correct. And the government agencies that we have in the previous counted on to provide us with the factual based information to support recommendations are going to be at odds with us. And I think what we have to do is in every instance, do whatever we can to eliminate the politics of this. It shouldn't be partisan. Stick with the facts, but the facts, unfortunately, for those individuals favor us, meaning those who have done the work to show that these vaccines are effective, they're safe, and we need them. And so I think we all are going to need to come together to figure out how do we best provide that information to the community and how does the community act on it?
Okay. Let's see, Dr. Brooks.
Yeah, Dr. Siegel might have had his hand up first, but
Okay.
I'll be brief. Well, two things. One is there was no modeling data presented today, which is fine because you did what you did. But we need data that shows what happens if you don't get vaccinated, because modeling helps to show the risks that you take. The other thing is there was no data presented today on equity. One of the 7 domains of ETR was equity, and I know you couldn't do them all, but going forward, I would like to be able to see data, which probably is in there, of subpopulations, specifically those at highest risk of complications of COVID, African Americans, Latinx populations, people with low income. That would be helpful to me as I'm communicate through the community that I have data that supports continued safety and efficacy and need for these vaccines, these 3 respiratory vaccines.
Okay, Dr. Siegel.
I agree with that point wholeheartedly, equity. And I want to add that nobody mentioned, and maybe somebody could comment on the issue of global data, because I'm in close contact with WHO, and obviously there's a lot going on with that on that end. But what is the current understanding? Does someone want to take a shot at that? Because global data wasn't presented today deliberately, and obviously you don't have access to the current government data in the United States, or all of that was very clear today. But I just wondered if somebody would comment on that.
Yeah, thank you, Dr. Siegel. Maybe I can take that one. I think, the case example that we provided about the potential safety and association of preterm birth with the RSV vaccine is such a beautiful example of why we need data from all over the world, from diverse populations, from different settings. I mean, this is, that's the only way we're going to be able to better understand potential safety signals and the effectiveness of vaccines for different populations. So I wholeheartedly agree with the importance of that. In our review for the outcomes of vaccine effectiveness, for safety signals, and for co-administration, we did include any data that were published, including from settings outside of the US. It was only for epidemiology that we really confined our results to the United States setting because trends and incidents of various infections are so setting specific. But where vaccine effectiveness data were presented from other countries, those were collected and reflected in our data. And there are many of the largest, highest quality data sets on some of these outcomes really are coming from other settings, from our European colleagues and others. And so we don't want to overlook any of those data, even though they're outside of our national borders.
All right, thank you. I'm going to turn it back to Dr. Osterholm to close us out.
Thank you, Kevin. I will somewhat edit my remarks on the fly here, as we already had a chance to discuss some of these points. But I just want to thank everyone who joined us today. And again, I want to express my deep gratitude to the team who analyzed what was truly a mountain of new immunization data for this respiratory virus season. It stands on the shoulders of the work that came before it. We appreciate that and honor that. What we have now today is based on this huge body of evidence that continues to demonstrate the effectiveness of immunization against COVID, influenza, and RSV, while serious adverse events are rare. Importantly, what you heard clearly today is the new data published since CDC's last comprehensive review does not indicate the emergence of a safety signal or sudden drop in effectiveness against these immunizations. As I just noted in my comments, there is no scientific evidence to support the changes HHS made to COVID recommendations for pregnant women or for children most at risk for high-risk transmission or severe disease. Rates of myocarditis in the pediatric literature the team reviewed are consistent with the prior literature and show no new safety signals for myocarditis with booster doses. In the general population literature, 2 studies were examined and one showed, if anything, a decreasing rate of myocarditis with time since the prior dose. Couple that with the most recent CDC data, which continue to show the vaccine's effectiveness at preventing severe disease and hospitalization. For RSV immunization, we did identify an area worthy of further exploration. We saw a previously known potential risk of preterm birth from RSV vaccine for pregnant women. And I just want to remind everyone, this is not the monoclonal antibody, but the vaccine administered to expectant moms. Post-marketing surveillance is underway, and this is an area that has been identified even prior to our review. One new study supported the effectiveness of influenza vaccination in pregnancy to reduce medically attended infection in pregnant women. For all other studies reviewed, COVID, RSV, and influenza vaccination in pregnancy resulted in similar or better outcomes compared to no vaccination. Of the close to 17,000 abstracts reviewed and nearly 600 papers extracted, autism was not raised as a significant adverse event. That's an important point to remember. Finally, vaccination of immunocompromised hosts continue to show efficacy against hospitalization in this high-risk population. As I just noted earlier, this morning, the American Academy of Pediatric announced its influenza, COVID, and RSV immunization guidelines for children. Their recommendations are consistent with our literature findings, specifically for COVID, that children at highest risk for severe disease and COVID transmission receive the COVID vaccine. Other medical societies will be following them in the coming weeks. Americans will have evidence-based immunization recommendations from medical experts for the virus responsible for tens of thousands of hospitalizations and deaths annually. And they'll come from clinicians who spend every day caring for these patient populations. America will also have the peace of mind that experts assembled by the Vaccine Integrity Project have independently analyzed information they need to decide how best to protect themselves and their families from these viruses. This webinar and the data shared today will be posted on our website, and as we continue the work, we will share more data with the American public. In closing, I want to again thank our panelists and our presenters and everyone else who turned in today. Thank you for being with us.
Great. Thank you, Dr. Osterholm. And again, folks can see the information there on that final slide for follow-up. Thank you, everyone, for joining us today, and special thanks to the panelists and our presenters.